Hi, my name is Isabel Chase, and today I will be going over kind of reviewing a couple things I talked about and explaining a little bit of my paper. I chose to look into unequal access, which is what I titled my paper, the impact of racial, ethnic, and socioeconomic disparities in the U.S. healthcare system. This topic is incredibly important to me, actually, not only as a student who's interested in public health, majoring in health science, wants to go out into the healthcare field, but also as a Native American who has experienced and witnessed the effects of these disparities firsthand, which I will talk about and go more into detail later. The goal of this paper is to present and shed light on how deeply rooted inequalities continue to harm communities of color and those from lower income backgrounds. My research explores how healthcare disparities in the United States affect racial, ethnic, and economically disadvantaged groups, especially Black, Hispanic, and Native American populations. These disparities come from a combination of historical injustices, economic limitations, and structural flaws in our healthcare system. This is also, by the way, just like a rundown of a couple things I talked about and went over in my paper. Despite efforts like the Affordable Health Care Act and Medicaid expansion, access and outcomes still differ dramatically. I argue that addressing these inequalities requires more than insurance. It requires cultural competent care, federal investments, and community-driven programs. I think one big change that needs to happen is for a lot of people to be more aware that stuff like this is still going on, and a lot of it has to do with things that happened a long time ago that are still affecting us today. To understand today's disparities, we need to look at the past, which is where a lot of this comes from. One of the most infamous examples of this is the Tuskegee syphilis study. For 40 years, Black men were denied treatment for syphilis without their consent, creating generations of trauma and deep mistrust in the medical system. Even after legal segregation ended, practices like redlining, uneven hospital funding, and discriminatory insurance policies kept healthcare separate and unequal. For example, the Hill-Burton Act provided federal money to build hospitals, but allowed separate facilities for white and Black patients under a separate but equal clause. These historical injustices still echo in our current system, where hospitals serving minority communities are underfunded and often lack specialist and adequate care. I think that's a big reason why you see people who live in richer neighborhoods, communities, tend to live a lot longer than those who are in low income areas. Today, we still see stark disparities in healthcare outcomes. Black patients are less likely to receive proper pain management due to outdated and racist beliefs about pain tolerance. Hispanic communities face language barriers, fear due to immigration status, and a shortage of cultural competent care providers. Many simply avoid care altogether. And in Native American communities like mine, underfunding is especially harmful. The Indian Healthcare Service meets about 54% of its patients' needs. In some areas, people drive hours just to see a doctor, and even then, care can be delayed or incomplete. So a little bit of personal experience to support some of this information is, as a Native American, I also go to a Native American health clinic. These are not just everywhere, they're on reservations, so I have to drive 45 to 50 minutes for dental or healthcare. Um, I have experienced providers, medical assistants, dental assistants who are not Native American, who are working there and do not provide you with the best and equal care. I personally believe they don't treat you the same that they would treat any other person. I feel like they have this kind of stigma that like you're here and you're getting free medical, dental care, so I don't need to treat you with the best of care, which is a personal thing, I believe, and have experienced. But if you were to ask other Native Americans, they would say the same thing. During COVID-19, the Navajo Nation was hit especially hard. Many households lacked running water, hospitals were overwhelmed, and the death rate was among the highest in the country. That's why that's what happens when a system is chronically under-resourced. Economic status is one of the most powerful indicators of healthcare access. Even after the ACA, about 28 million non-elderly people remain uninsured in 2020, most of them from lower income households. People often skip doctor visits or medications because they simply can't afford them. Even with insurance, high deductibles, and copays, they can make care feel out of reach for a lot of people. Those in low-wage jobs often don't get insurance at all, and when choosing between paying rent or paying a medical bill, your health is going to suffer no matter what, mentally or physically. And unfortunately, these economic struggles are closely tied to race and ethnicity due to systemic inequality in employment and education. Healthcare isn't just about hospitals or doctors, it's also about where you live, what you eat, and how safe your environment is. If someone lives in a food desert where there's no access to affordable, healthy food, they're more likely to develop conditions like diabetes or heart disease. If public transport is lacking, it's harder to get appointments. If housing is unsafe, mold, overcrowding, this leads to exposure. It creates long-term health issues. All of these are examples that I do talk about and are examples of what we call social determinants of health. They affect every aspect of your well-being and hit marginalized communities the hardest. Legislation like the Affordable Health Care Act and Medicaid expansion made a real difference, especially in states that adopted the expansion. More people got covered, costs went down, and healthcare became more accessible. But the work is not done. Some states still haven't expanded Medicaid, which leaves millions, especially Black and Hispanics and Native Americans, without equal access. Even those with insurance still struggle with provider shortages and the bias in medical treatment. To create a real change, I strongly believe that we need policies that go beyond coverage. We need to address systemic racism in healthcare settings, which is still happening, and nothing that I know of is being done about it or have learned about, nothing. Train providers in cultural competency and ensure every community has the infrastructure it needs to thrive. It's literally proven that if you live in a low-income area compared to high-income areas, you are already at a disadvantage. And in no way is that fair to anyone. So, what can we do? What are a couple changes that could push us in the right direction to fix these? There's not one single fix, but there are several important steps that we can take These all are talked about in my paper, but I will go a little more into depth on each one of these. So first, we need to invest in community-based healthcare, especially in Native and rural communities. These programs understand local culture and provide consistent, accessible care. I think investing in Native American health clinics is extremely important. And second, we need to support traditional healing alongside modern medicine. The American Indian and Alaskan Native Cultural Wisdom Declaration calls for honoring spiritual and cultural aspects of wellness, not just physical health. I strongly believe that if a lot of people were more open to diversity and other ideas, things would be a lot different. Third, we must train healthcare providers to recognize and reduce their implicit biases. This builds trust and improves communications between patients and providers. And finally, we need to keep pushing for federal funding and equitable policies that address economic inequalities and healthcare gaps. In closing, I think healthcare disparities in the U.S. are not just unfortunate, they're unacceptable. They're the result of decades of discrimination, underinvestment, and systemic failures. As a Native American and a future public health profession, I believe we have a responsibility to fight for equity. This means listening to impacted communities, funding what works, and remaining a healthcare system that serves everyone, regardless of your race, your income, and your zip code. Lastly, I am going to just do a quick overview of the structure of my paper. So the first I talk about the historical context of healthcare disparities, which I talked about. I talk about how systemic racism shaped healthcare access. Some key points I talk about are the Tuskegee syphilis study and its lasting mistrust and how it's still affecting us today. Hospital segregation and Jim Crow laws. The Hill-Burton Act, which allows separate but equal facilities, and then the long-term impact of chronic disease and resource gaps due to low-income areas not receiving equal access to stuff. I then go into talk about racial and ethnic disparities in healthcare. This talks about the modern inequalities in treatment and outcomes by race. Some key points I make here are the implicit bias in treatment, such as pain management, the language barriers and immigration fears for Hispanic patients, the underfunding of the Indian Health Service, and the COVID-19 impacts on indigenous populations like the Navajo Nation. I then go into economic barriers to healthcare access. Here I talk about how income affects access to healthcare. Some key points I made here are the lack of insurance among low-income individuals, high out-of-pocket cost even with insurance, uninsured delays leading to worse outcomes, employment-related disparities in access, no sick leave or benefits. I then go into talk about social determinants of health and healthcare access. The topic was education, housing, transportation, and food security. Some key points I make are lower education, which equals lower health literacy, poor housing conditions and environmental hazards, food deserts and diet-related chronic illness, the lack of transportation that reduces healthcare access. I then talk about the role of policy and legislation in healthcare inequalities. That topic was government policies and their mixed effectiveness. Some key points I made there were the ACA and Medicaid expansion success stories, gaps due to the states opting out of Medicaid, persistent problems of high deductibles and provider biases, the need for comprehensive reform beyond insurance coverage. Lastly, I talk about the potential solutions and future directions. My topic was to reform strategies in cultural competent care. Some key points I made here were integrating traditional healing in Native healthcare, cultural wisdom, declaration and community engagement, more funding for the Indian Health Service and tribal programs, and cultural competent training and structural reform. Overall, I believe disparities need to be called to action, and I learned a lot and had a very good time writing this paper. Hopefully my paper can be used in the future to help educate other people on maybe something they didn't know was still going on. So thank you for listening.